Good evening, everybody. I would first like to thank my Dr. Vijayakumar who gave me this opportunity and the 3D committee. So my topic is going to be on new onset of diabetes after transplant. So the purpose of transplantation is to ameliorate the cardiovascular risk factors. But the problem is with the immunosuppressants that interferes here and it introduces new cardiovascular risk including impaired glucose tolerance, diabetes, hypertension, dyslipidemia, etc. So this is a problem. And NODAT is it's a very serious and a common complication because it invariably increases the fatal and non-fatal cardiovascular events including infection, reduced patient survival, graft rejection and accelerated graft loss comparatively. So you have to identify the high risk patients, and if you implement accordingly the measures to reduce the development of NODAT, they may have improved long-term patients and graft outcome will be there. And you can see the incidence. New onset of diabetes after transplant has been reported to occur in you see different transplant. You can see the incidence is more nearly 4 to 60% is the incidence rate. And these are the non-modifiable, potentially modifiable and modifiable risk factors. We will see one by one. And the risk factors, as the age increases, we all know age increases, any complication, any hazard is going to be increased. And your race and ethnicity, African American and Hispanics have been increased because of the differential pharmacokinetics and the diabetogenic effect of the immunosuppressive agents. And the family history, the first degree relatives have an increased risk of developing NODAT, and other non-modifiable risk factors like HLA, HLA-A30, B27, B42 and increasing HLA mismatches, donor recipient mismatch, deceased donor kidneys, male donors and acute rejection history. In this modifiable risk factor, one important thing is this corticosteroid associated NODAT, it is dose dependent, and you can see in recent years several studies have suggested a potential benefit effect of steroid free immunosuppression on NODAT risk reduction. So that is very important. And overall steroid containing regimens at the time of hospital discharge were associated with a 42% increased risk of NODAT. So it is important that frequently adopted steroid free regimens had reduced odds of NODAT. And we come to the immunosuppressants like calcineurin associated NODAT, cyclosporin versus tacrolimus. Certainly tacrolimus has more consistently been shown to have a greater diabetogenic effect. Then across renal and non-renal transplant groups, tacrolimus has shown to be increased diabetogenic effect. Next comes the interaction between the tacrolimus and the hepatitis C infection. In a retrospective study of more than 400 kidney transplant recipients with known pre-transplant diabetes, Bloom and colleagues have shown that among the HCV positive cohort, NODAT occurred more often in the TAC compared with the cyclosporin treated groups. So in contrast, among the HCV negative cohort, the rates of NODAT were similar between the two calcineurin inhibitor and the TAC versus cyclosporin. But sirolimus, again, it is a very diabetogenic, it has a very high diabetogenic effect. With sirolimus it's seen and it has been well described, and here you can see this USRDS data of nearly 20,000 primary kidney transplant recipients. Sirolimus was associated with an increased risk of NODAT independent of any effect of tacrolimus. And the effect of antimetabolites, very important. Acetopyrin and MMF allows clinicians to use low doses of other diabetogenic immunosuppressive medication. So this has to be kept in the mind. So what is the potential pathogenic mechanism of this immunosuppression agents? You can see corticosteroids, it decreases the peripheral insulin sensitivity, inhibits pancreatic insulin production and increases hepatic gluconeogenesis. Cyclosporin, again it reduces the insulin secretion, synthesis is reduced, beta cell density is reduced, and this is the pathophysiology behind the immunosuppressions. And once this all depends upon the dose, and once if it has been combined with steroid, and it is going to be doubled. And obesity, we all know this is also a strong risk factor for NODAT. Your hypertriglycerides, hypertension, your proteinuria, all these are things. And when you come to hypomagnesemia, there is an association with type 2 diabetes. Similar to the non-transplant settings, hypomagnesemia has also been shown to be an independent predictor of NODAT in recipients and in renal and liver transplants. But the association between the use of CNI, that is calcineurin inhibitor, was strongly related to hypomagnesemia. But whether magnesium supplementation and correction of magnesium deficiency reduce the incidence of insulin resistance or NODAT remains to be studied. So potentially modifiable risk factor, as I told you, IGT, diabetes, other things are there, and HCV-associated NODAT can be prevented if there is a successful pre-transplant treatment of the hepatitis could potentially reduce the incidence of NOD. And cytomegalovirus, it has there is a suggestion that impaired pancreatic beta cell insulin release may be involved in the pathogenic mechanism of the cytomegalovirus associated NODAT. And the impact of NODAT on patient and allograft outcomes are a 2 to 3-fold increased risk of fatal and non-fatal cardiovascular disease events as compared with non-diabetic patients. So, detection and management of diabetes mellitus, you can see here pre-transplant baseline evaluation, complete medical and family history, glucose history, fasting plasma glucose, 2-hour glucose tolerance test has to be done, and identify the high-risk candidates, and accordingly you can intervene. In pre-transplant, counseling is important, weight control, diet and exercise. Consider pre-transplant treatment of hepatitis C viral infection, and post-transplant individualize the immunosuppressive treatment. Fasting plasma glucose has to be done weekly for the first month, then at 3, 6 and 12 months, then at least annually after first year. Consider OGTT when normal fasting plasma glucose or glucose intolerance is seen. Early detection of NODAT after transplantation is very important. For that you need a OGTT at 10 to 12 weeks post transplantation, might help you to detect early. And management is very simple, it is conventional only. And you can see all the other agents what you use in diabetes, you can use it for same for NODAT also. But modification of immunosuppression is very important. Corticosteroid dose reduction has to be shown very significant improvement in glucose tolerance, and steroid sparing regimens should be tailored, and use of combination therapy with like CNI and TORC has to be probably avoided in this situation. Renin-angiotensin, you know, the incidence of type 2 diabetes is reduced and we know the benefits, well established antiproteinuric, cardioprotective and blood pressure lowering effects are seen with this thing. So pharmacology management is very conventional. Incretin based therapy appear to provide an attractive treatment option for patients with NODAT owing to its favorable effect on weight reduction and weight neutrality. Well-diagnosed treatment should be used according to the EGFR. Finally, drug-to-drug interaction should be carefully considered. In summary, NODAT is a common complication after solid organ transplantation and has invariably been reported to have an adverse impact on patient and allograft outcomes. So, risk stratification and intervention to minimize risk should be an integral part of the management of transplant recipients. So, when lifestyle modification fails to achieve adequate glycemic control, medical intervention is often necessary. So, management, I put it simply, non-pharmacological, dietary, dietitian, manage dyslipidemia, everything. Modification of immunosuppressive medication is very important. Before that, the physician should understand the immune profile of the patient. Accordingly, you can give this immunosuppressive medications. Finally, pharmacotherapy, I told you it is conventional method only, but monitoring of these patients notice HbA1c every 3 months, screening for microalbuminuria, regular ophthalmic exam, regular food care, annual fasting lipid, and aggressive treatment for dyslipidemia and hypertension. Thank you.